The first step in hysteroscopic endometrial ablation is the anatomical survey of uterine cavity, that is the diagnostic hysteroscopy, which is done with 5 mm continuous flow operative channel Batoki sheath. I have skipped this step since I am using 18.5 French bipolar mini resectoscope. I am using a 30-degree telescope, and bipolar mini resectoscope, that is 18.5 French, is almost 6.13 mm. I have attached roller ball electrode to it. I enter the uterine cavity with 18.5 French bipolar resectoscope with a roller ball electrode attached to it. As I enter the cavity, I observe both the ostia and all the walls of the uterine cavity, and then gradually from one ostia to another, I start doing electrodesiccation of the fundus, that is the line joining both the ostia. Look at the blanching, it's absolutely white. So gradually, step by step, you go from one end to another, coagulating the fundus. You have to touch the fundus and press the pedal for a transient period of time, maybe 1 second or a fraction of a second. This is the line of fundal electrodesiccation.
The third step in hysteroscopic endometrial ablation is ostial desiccation, which is relatively critical. Avoid if you are planning for Mirena insertion along with hysteroscopic endometrial ablation. Now, why we should avoid it? Because ostia is the most thinnest part. The thickness at the ostia is 5 mm only. It is a relatively difficult step. The chances of intraoperative complications like perforations are very high. Postoperative complications like hydrosalpinx, hematosalpinx are also high. What happens is that when you desiccate the ostia, there is a fibrosis, so the tubal secretions get accumulated, resulting in hydro or hematosalpinx, giving rise to severe low abdominal pain, that too after few months after the surgery. So I usually avoid ostial desiccation if I am planning for Mirena insertion along with hysteroscopic endometrial ablation. The endometrium at or around near the ostia is taken care by the Mirena. So I avoid this step, and I also advise the young generation, if you are putting a Mirena inside, avoid this step. Now let's see how ostial desiccation is done. Go near the ostia. Make a contact of ball electrode with the ostia. Don't press at the ostia. Decrease the intrauterine pressure so that the surrounded ostial tissue will roll around the roller ball. Third is press the desiccation current for a transient period of time and then stop pressing it and then increase the intrauterine pressure again. Don't try to press the pedal and touch the ostia with high intrauterine pressure. You have to decrease the intrauterine pressure transiently. Okay, so the steps are enumerated. Touch, reduce the intrauterine pressure, press the pedal, that is the desiccation current, stop pressing the pedal, and then increase the intrauterine pressure. You got it? So again here, touch the ostia, decrease the intrauterine pressure, press the desiccation current for a transient period of time, stop pressing the pedal, and then increase the intrauterine pressure again. Now this is the final picture of ostial desiccation. You can continue at each ostia for 2 to 3 times or till complete ostial blanching is seen. Now let's revise the steps of ostial desiccation again. Now the first step is touch the ostia. Make contact with the ostia. Make contact of the roller ball with the ostia. Do not push or press harder or you will perforate the ostia. Remember, do not push or press. This is very important. Only just make a gentle contact with the ostia. Coming to the second step of ostial desiccation. The second step is reduce the intrauterine pressure for a transient period so that the uterine cavity collapses and the surrounding tissue covers the roller ball electrode completely. Now, how to reduce this pressure for the transient period of time, we'll talk about it later on with the demonstration. So this is a very important step. The third step of ostial desiccation is P. Press the pedal of electrosurgical unit. That is the desiccation current, that is the yellow pedal should be pressed for transient period, maybe for a second or a fraction of a second. Do not press or push the ostia with the electrode, otherwise you may perforate the ostia. Complete ostial blanching should be noted. You can repeat the procedure twice. So, the fourth step of ostial desiccation is you should stop pressing the pedal. That is, don't pass the current. Remove your foot off the pedal. The fifth step is increase pressure to the set intrauterine pressure so that you can observe the ostia and the periosteal region for blanching. One more important point, when the uterus is distended, do not give pressure to the ostia with the roller ball. Otherwise, the chances of perforation is high. So let's revise the steps of ostial desiccation. Step number 1, T, which stands for touch the ostia with the roller ball electrode. Second, R, R stands for reduce the intrauterine pressure. Third, P, P stands for press the pedal, that is pass the current. Fourth, S, which stands for stop pressing the pedal, that is eliminate the current. And lastly, 5, I, which means increase the intrauterine pressure and watch the ostia and periosteal region.
How to decrease the intrauterine pressure? This is a very important step in ostial desiccation for which your assistant or OT staff should be well trained. First is by reducing the pressure on the hysteroscopic pump. You can manipulate the button and then decrease the pressure as shown in this video. Second method is manipulating the inflow channel. That is, you can partially close the inflow channel of the resectoscope and thereby decreasing the intrauterine blood pressure. This is shown in the video very nicely. Now the third method is kinking or pinching the inflow tubing. Now as shown in this photograph, you have to just kink the tubing. The assistant has to do the job. Look at this video.
Whichever method you use, the role of assistant is very important. Decreasing the intrauterine pressure with the help of hysteroscopic pump or by kinking the tube is done by the assistant itself. By manipulating the inflow channel is done by the surgeon. It's difficult, but if the surgeon is experienced, then he or she can manage it itself. The assistant should be smart, intelligent enough to know when to decrease the intrauterine pressure and should be able to recognize the sign of decrease in intrauterine pressure. So while doing the maneuver of reducing intrauterine pressure and to recognize the sign of decreasing intrauterine pressure, the assistant's eyes should be constantly watching the monitor, observing the real-time surgery. The surgeon and assistant should have a verbal communication during this step and should have a synchronous action.